Today is all about blood transfusion reactions. Thanks for visiting my channel. Please remember to subscribe if you haven't. But if you are a visiting subscriber, I'm saying a big thank you. Without further ado, let's go straight to blood transfusion reactions. I have a long presentation on everything that we should know as per blood products transfusion, including blood transfusion reactions. If you click on this very link, it will take you to that very presentation. It's about 2 hours, 55 minutes. But because many people will not have the time to sit down for 2 hours, 55 minutes, I've decided to bring this out of the very long presentation. Transfusion reactions is known also as transfusion complications. It may be acute, and that could occur within minutes of the transfusion or to the end of transfusion up to 24 hours. The delay may occur days after, months, or even years. Remember that before we will start transfusing, we must take vital signs, right? And then we would have recorded the baseline temperature. In mild febrile non-hemolytic transfusion reaction, there will be a mild rise in the temperature. The rise will be about 1 degree Celsius, but there will be no rigor, no chills, no allergic reactions, no anaphylaxis, no transfusion-associated circulatory overload, no transfusion-related acute lung injury, no transfusion-associated graft versus host disease, no hemolysis. If that is the case, then the transfusion can continue, and then we'll give acetaminophen with Benadryl. If you want further full explanation, please click on this very link. Now, outside the mild febrile non-hemolytic reaction, any other reaction, we have to stop the transfusion. Check the patient, stabilize the patient, notify the patient or substitute decision maker or the parent if it's a child. We send the blood back to the blood bank. We will quickly administer the appropriate medications from the kit that we've got. The kit would have contained EpiPen or adrenaline, corticosteroids, Benadryl, albuterol, avifluid, tranexamic acid, intravenous globulin, lasers, and so on, depending on what is obtainable in your jurisdiction. Somewhere there's acetaminophen, not to worry. So further explanation could be obtained from the presentation I've already published through this link. We don't rush when it comes to blood product transfusion. If we give too much, that is massive transfusion, or we give it too rapidly, we can run into arrhythmia, fluid overload, heart failure, hyperkalemia, hypothermia, hypocalcemia, pulmonary edema, or dyspnea. For further full information on all this, please click on this link. It might be acute problem, acute complications that are not infectious in nature, could be because we are using wrong blood. Then it might be agglutination reaction, allergy reaction, urticaria, anaphylaxis, or acute hemolytic reaction. Well, further information can be obtained through this very link. Still non-infectious but acute in nature, anaphylactic reaction, coagulation problems, particularly if we are transfusing a large quantity. Might be febrile non-hemolytic reaction that is not mild, moderate, or severe, like metabolic disorders or bacterial contamination. So acute complications could be allergic reaction. In that case, could be mild with urticaria, pruritus, and hives, but may be life-threatening. When it is life-threatening, we're talking of anaphylaxis, with shortness of breath, swelling in the leaves, along the throat, along gastrointestinal tract, everywhere, hypotension, stridor, hives, rashes, anaphylactic shock, and death. Please don't confuse allergic reactions to angioedema. I have given full explanation on the disparity between allergic reactions and angioedema. One major obvious disparity is that allergic reaction will come with urticaria and hives, but angioedema will not have urticaria, but can have swelling. And angioedema is all about bradykinin induced. Further explanation could be gotten when you click on this very link. For further explanation or pieces of info on angioedema, because we have acquired angioedema, we have hereditary type 1, hereditary type 2, and hereditary type 3 that have surfaced in medical literature just in the last 2 decades. All are right there. You can click on each of these separately to lead you to that. How can we prevent allergic reactions or anaphylaxis? It will occur mostly when IgA deficient patients receives IgA with antibodies or anti-HLA and anti-complement. So we don't give plasma with IgA to IgA deficient recipients. In that case, we have to use washed product. And even with that, we'll keep an eye on the recipient in the first 15 minutes of transfusion. Acute hemolytic reactions. It could be immune or non-immune. Intravascular in case of ABO antibodies or extravascular in case of immunoglobulin or complement attack in liver or spleen. The acute hemolytic reactions could be immune mediated within 24 hours. Here, there will be destruction of the transfused red blood cells. What is happening? The transfused red blood cells will be attacked by the recipient antibodies, and mostly due to ABO antigen antibody reaction. Allo antibodies to other red blood cells antigens after past pregnancies or transfusion is a possibility. The non-immune causes of acute hemolytic reaction will include bacterial overgrowth, improper storage, like I've gone through how to properly store all these different products at what temperature. Those that will be treated like platelets at room temperature and should be stored for so number of days, all have been stated if you click on this very link. Then incompatible medications, small bore IV lines, hypotonic solution, you understand what it is when fluid will move from region of lower concentration to region of higher concentration. You know what is going to happen. So I have given full explanation if you click on this very link. Back to febrile non-hemolytic transfusion reactions. Like I said, mine febrile non-hemolytic transfusion reaction earlier on, that the temperature is going to rise just a little bit above the baseline, but it's going to occur within 24 hours, like minutes, 24 hours, like the mine case. The difference is that the temperature will be above 37 degrees Celsius. There will be no rigor in mine cases, but there will be rigors that will be cheese there, and the patient will feel some level of discomfort. We are going to make these diagnoses after ruling out other causes of febrile illness and whatever could lead to rigors and chills. So after then, we'll come down on febrile non-hemolytic transfusion reaction. Okay. Here, the pathogenesis will involve cytokines and pyrogens. I've given detailed explanation if you click on this variant. Like I said, I'm making this to be pretty fast to those who don't have the time to sit down for 2 hours and 55 minutes. But you can click on this link if you want further information. Transfusion-related acute lung injury. This could take a long time, but I'm going to summarize it here. That it is related to transfusion, okay, of blood product. There is no problem with the heart, but there's pulmonary edema. This is a diagnosis of exclusion because you've ruled out other causes of pulmonary edema. Nothing but transfusion related. There will be acute hypoxemia, understandably so, right? And this can occur as quickly as 6 hours, around the time that the individual received the blood product. It is more likely if we are using plasma, we are getting plasma from a donor who is a multiparous woman. Many times to all women worldwide, we appreciate the fact that you've been donating different products and using them over the years. Bravo. But when it comes to transfusion-related acute lung injury, and we don't want that to keep on occurring, we will settle down for plasma donated by male donors only. This, started in the United Kingdom. The brilliant blood transfusion experts from UK decided that, I think we should change the direction, right? We would rather be taking plasma for male donors only, no longer from multiparous women. That, of course, we expect the society to kick against that, right? So many doctors were uncomfortable. They thought it would be a form of discrimination, and so on. No, it has to do with alloimmunization, and then, attracting more immune cells settling in the lungs, and that will lead to more secretion, and then more fluid will be built in the lungs. So that is why male plasma will give less trouble when it comes to this compared to multiparous, women's plasma. So most blood transfusion-related deaths could be traced to this very problem. The pathogenesis I've explained further if you click on this very link. But because I want to make this shorter than the 2 hours 55 minutes, I would rather end the story right now. That click on this very link. I've given you further explanation why male plasma donors will have less trouble when it comes to transfusion-related acute lung injury, and female or multiparous women's plasma will give us more trouble. But we appreciate women. Thank you. TACO is transfusion-associated circulatory overload. Here, large volume has been given more than what is required, or it has been given in a faster rate than it is expected. So, 1 unit at a time, and don't rush. Here, there's no antibody issues. Still on TACO, it's going to occur mostly in people with pre-existing conditions like cardiovascular disease, renal failure, anemia, too young people, or elderly, meaning they will have transfusion-associated circulatory overload in all these conditions. If you want further explanation, click on the link that will take you to 2 hours 55 minutes. TACO clinical features will include tachycardia, cold dyspnea, hypertension, increased central venous pressure, increased pulmonary wedge pressure, wide pulse pressure, cardiomegaly, that is, if it is there for a long time, right? And of course, pulmonary edema. How can we make the diagnosis of transfusion-associated circulatory overload? Now, we can do that clinically. The history of transfusion is right there, right? And of course, further history to rule out, whatever could be responsible for the signs and symptoms already, picked, right? Underlying medical problems and so on. Okay. Then we'll do physical examination, general inspection. We'll palpate, percourse, auscultate both the cardiovascular and respiratory systems. Then we'll head to lab. We'll do many investigations, but one will stand out. That is BMP. BMP will help in distinguishing whether this is cardiovascular problem or it is limited to the lungs. So it will, with the help of BMP, we'll be able to eliminate transfusion-related acute lung injury. because BMP will be within normal range, if it is limited to the lungs only. But if the circulatory overload is the issue, then BMP will not be within normal range. For you to know more about BMP, you can click on this very link. And for further explanation on diagnosis of TACO, you can go to the long presentation on blood product transfusion through this link. Now, in TACO, if you don't want the problem, then prevent it, right? Don't rush and don't give too much volume of products, okay? Adopt non-liberal transfusion, meaning give only one unit. Review later on. Now, the clinical state will determine if you're going to give more or not. Now, transfusion-associated graft versus host disease. This is a long topic, but I'm just going to summarize it there. If you want full info, you can click on this very link. We can get out of this very problem if we give irradiated blood components. That will help in preventing transfusion-associated graft versus host disease. It's a very rare condition. Well, that is the light at the end of the tunnel that we can pick here. But that is not in immunocompromised patients. In immunocompetent, it's very rare, it's not likely going to occur. But to those who are immunocompromised, now somebody that is having long-standing diabetes mellitus, somebody that is HIV, now coming down with AIDS, someone on chemotherapy, someone on long-term corticosteroid use, someone that is using disease-modifying anti-rheumatic drugs, all these category of patients are too old when immunity is waning down, or too young when immunity is not mature enough. All these cases can lead to this. And it is a serious condition. You could see that I didn't rush through it all. This is a serious condition because mortality is pretty high here, as high as greater than 80%. In fact, some literature will put it as greater than 90%, meaning 9 out of 10 people affected will likely die. It's a serious issue. If you want further information, click on this. I'm not done yet. I'll still talk more on this. Let's go. The possible risk factors, just quickly, let me get through this very quickly. It will be direct donations from family members with shared halotypes. Also, newborn with cardiac-related abnormalities, meaning the newborn is not having strong immunity, but the immunity is even one thing. Another thing is cardiac anomaly. HLA match, meaning donors transfusing to recipient with the same HLA. Immunocompromised recipients now. The donor is not having problem, but the recipient is having immune-compromised state, like HIV, AIDS, and so on. Intrauterine transfusion until gestational age of 40 weeks is a risk factor. And newborns with a chain blood transfusion is a risk factor for transfusion-associated graft versus host disease. Other risk factors will include Hodgkin lymphoma or hematological malignancies altogether, solid tumors treated with cytotoxic agent. Why would that be? When someone is on chemotherapy, immunity is down. And then side medications like fludarabine. What is fludarabine? It is a chemotherapeutic agent, of course. Hematopoietic stem cell transplant recipients, the Jaw syndrome, severe combined immune deficiency or cell-mediated immune deficiency, prematurity with low birth weight. All this, immunity will be down. Then, transfusion-associated graft versus host disease will surface. Okay, further to that is that T lymphocyte is responsible, but we don't know the exact quantity of the T lymphocytes that could lead to that, just as the case is with fetal alcohol spectrum disorder, where we don't know the exact quantity of alcohol that could tilt the newborn to this. So all we know now is that we have clinical features that will be not specific. So non-specific signs and symptoms. But within 1 week, there'll be more bone marrow failure. And at 4th week, there'll be pancytopenia. I think we can reason with that if bone marrow has failed, then we'll be running into pancytopenia because all blood forming cells are underperforming right now. And you know the meaning of that when there's pancytopenia. Red blood cells down, white blood cells down, platelets down. Of course, we're in trouble. So there'll be diarrhea, hepatitis, rashes, and fever. Death will be due largely to pancytopenia. Of course. Why that? There'll be bleeding from thrombocytopenia. And of course, there'll be infection from leukopenia. Imagine, profound neutropenia. That is a serious issue, right? And that's what will actually kill the patient, bleeding and infection. If you want further information, please kindly click on this very link. Now, target organs here will be skin, the bone marrow, we've explained, extravascular, the GIT, the liver, the intestine, and so on. That is why diagnosis could involve skin biopsy for pathology. Diagnosis. We have to assay for donors T lymphocyte because we know T lymphocyte is responsible. And we're not going to get that from the donor, but we'll get the T lymphocytes of the donor in the recipient's blood. Then we have skin biopsy for pathological studies. Remember, target organs will be skin, the bone marrow, then gastrointestinal tract. Treatment. Well, no effective treatment per se. We'll only give supportive. The cure is only if there is that possibility for a rapid hematopoietic stem cell transplantation. That is the way up. Prevention is better than cure, and we could do that with irradiation of the components before transfusion. Okay, to get out of this problem, then there are preventive measures that we can take. Well, it is a common saying that prevention is better than cure. So we can do that with irradiation of the component of the blood transfusion. So if we don't want this, then let there be irradiation of the following: whole blood. Although many people don't give that anymore, but in case you are forced to do that, then let it be irradiated. Watch red blood cells, platelets from bovine coats or platelets from apheresis, cellular units donated by a family member, granulocyte concentrate, and HLA-matched platelets all should be irradiated. Now, delayed or prolonged complications. The non-infectious causes of that could be iron overload. I'll not waste your time. This is the link to hemochromatosis. So everything about iron overload and hemochromatosis, you get that right here. Could be delayed hemolytic reaction or post-transfusion purpura. The acute cases that could remain in the system or remain a problem for the recipient for a long time, otherwise prolonged complication, could be transfusion-associated growth versus host disease, transfusion-related acute lung injury, transfusion-associated circulatory overload. All these could occur acutely, but then could remain in the system for a long time. Transfusion-related immunomodulation, Anaphylaxis or allergic reaction can occur quickly, but by the time you are treating and facing the complications, the patient may suffer for a prolonged period of time. Febrile non-hemolytic transfusion reaction, and the list goes on. Now, infectious complications may be faced with hepatitis B or hepatitis C. Here we'll be dealing with chronicity of these viruses and then the probability of hepatocellular carcinoma. HIV or COVID-19. So we have to screen for them. Human T lymphotropic virus 1 and 2. Malaria in malaria endemic zones of the world. Babesiosis, West Nile virus, Creutzfeldt-Jakob disease. This is not the way many people will abbreviate it. They will write CJD or VCJD when you're talking about a variant. So if you want to know more about Creutzfeldt-Jakob, please click on this link. And for further explanation on all this, you can click on this very link. In conclusion, the importance of blood cannot be overemphasized. Some believe that blood is life. Massive blood loss will be equal to death if no blood transfusion quickly enough. I started with right product, right person, right place, right time. Let me end with right product, right person, right place, right time, and then right route and right dose. Long live the medical service to humanity. I've just decided to rush through all this. If you want further pieces of information or explanation, please kindly click on this very link. Thanks for listening. Remember to share this. Remember to subscribe to my channel. I appreciate it.